Hello, everyone. Today we're going to be looking at a very important skill in nursing, which is ECG analysis and identification of cardiac rhythms. So, as nurses, you will frequently encounter patients with heart rhythm disturbances, ranging from harmless to life-threatening. So, understanding dysrhythmias is very important for being able to recognize those early warning signs so that we can intervene appropriately so that we can ultimately improve our patients' outcomes. So in this lecture, we're going to be looking at the electrophysiology of the heart, common dysrhythmias and their causes, their clinical manifestations, and their management. And most importantly, we're going to be talking about your role as a nurse in assessing and responding to these different conditions. So let's get started. So now let's talk about electrocardiography, or ECG, which is one of the most essential tools to assess and diagnose a cardiac dysrhythmia. So an ECG provides a graphic representation of the electrical activity of the heart. It doesn't show the actual structure of the heart, but it helps us identify any changes in electrical conduction that may indicate ischemia, infarction, electrolyte imbalances, or even different medication effects. So to understand ECG interpretation, we need to first discuss two key terms. First is depolarization. This is the electrical impulse that activates the heart, which causes the muscles to contract. Repolarization is when the heart muscle relaxes and resets for the next contraction. As nurses, your role is to recognize any abnormal rhythms and to understand their clinical significance so that you can respond quickly and appropriately. Mastering ECG interpretation will help you to provide that safe and effective care for our patients. So now let's take a closer look at how an electrocardiogram or an ECG works and how electrical activity is displayed. So electrodes are going to be placed on specific locations on the skin, and they're attached to cables or leads that connect to the ECG monitor. These electrodes detect the heart's electrical activity as it transmits through the body, and each lead provides a unique view of the cardiac electrical conduction, which allows us to assess rhythms and to detect abnormalities. The ECG waveform is based on a lead system that consists of positive and negative poles, and the baseline, or the isoelectric line, represents a resting state. So a positive deflection occurs whenever the electrical flow moves toward the positive electrode, and a negative deflection occurs whenever the electrical flow moves toward the negative electrode. The various deflections represent the phases of depolarization and repolarization within the heart. So by understanding how these lead systems work, you're going to be better equipped to interpret the changes in the waveforms and recognize abnormalities such as an ST elevation or a T wave inversion or some other signs of cardiac dysfunction. This knowledge is key to detecting life-threatening conditions early so that we can ensure those timely interventions. So now let's discuss ECG lead systems and proper electrode placement. Correct lead placement is very important for us to get an accurate rhythm interpretation so that we can avoid any false readings. A 5-lead ECG system is very commonly used for continuous cardiac monitoring, especially in the hospital setting, and that's what we see here on the slide. It consists of color-coded electrodes that are placed at very specific locations on the body. So white goes on the right arm, and an easy way to remember this is white is right. Then black is going to go on the left arm. So with this, we think of smoke over fire because black comes before the red, and the red electrode goes on the left leg, again completing that smoke over fire pattern. Then green goes on the right leg. When this follows the clouds over grass memory trick, where the green represents the grass, and the white on the right arm represents the clouds. Then the brown, which is the V1 position on the chest, oftentimes near the sternum. With this, we want to think of dirt in the middle. Again, it's going on that right side between the grass and the clouds. So these lead placements allow us to monitor electrical activity from different angles, and so that we can identify any potential cardiac issues more effectively. Whenever we place these electrodes or these leads, we always want to make sure that the skin is clean, it's dry, and it's free of any lotions or hair that might interfere with the signal quality. All right, so now let's talk about the 12-lead ECG system, which is one of the most commonly used diagnostic tools for cardiology. So although it's called a 12-lead ECG, it actually only uses 10 electrodes, but it provides 12 different views of the heart's electrical activity. So we want to think of leads as different camera angles that are capturing the heart's conduction system from multiple perspectives. So the 12-lead ECG consists of 6 limb leads, which provide a frontal plane view of the heart. So these are like that 5-lead system, but they actually include an additional lead to complete the set. They're going to be placed, again, on the arms and the legs to assess that electrical activity from multiple different directions. So then here's where we add on here. The 6 chest leads, which are also called precordial leads, are also going to be placed across the chest in a horizontal plane. And this gives us a detailed view of the electrical conduction in the heart's ventricles. So let's talk about patient teaching for a 12-lead ECG. Say we're going to come into the room and we're going to do an ECG on a patient. First, we want to prepare this patient properly just to make sure that we get that accurate reading. So first, we're going to instruct the patient to remain as still as possible because even small movements can create artifact, which leads to misinterpretation. The patient needs to be in a semi-reclined position to allow optimal lead placement and for comfort. And we want to encourage them to breathe normally, but to avoid any excessive talking or deep breathing because this can distort the ECG tracings. A 12-lead ECG is such an important tool to be able to diagnose conditions like a myocardial infarction, myocardial ischemia, electrolyte imbalances, and different conduction abnormalities. So mastering that proper lead placement and patient preparation will help you to obtain that clear, reliable result, which is needed for timely diagnosis and for treatment. So now let's break down ECG waveforms and how to interpret them using the ECG graph paper. An ECG strip is printed on standardized graph paper where time is measured horizontally and voltage or amplitude is measured vertically. Now looking at this graph paper, you can see, especially on the top graphic there where it's kind of zoomed in, there are some small squares within a large square. So each small square represents 0.04 seconds. And each large square, which has 5 small squares in it, represents 0.20 seconds. Now, when we have 5 large squares together, that equals 1 second. 15 large squares is 3 seconds, and 30 large squares equals 60 seconds, which is a key reference for calculating our heart rate. So if you look at that bottom, either the top or the bottom graphic there, you can see at the very top of the graph paper there are some little tick marks, some little black tick marks. So the time in between each tick mark represents 3 seconds. So you can see on the bottom slide there, there's that total of 3 tick marks. Between the first one and the second one is 3 seconds, and between the second and the third one is 6 seconds, for a total of 6 seconds. Now this is very important whenever we're trying to calculate heart rate, because we're going to calculate heart rate by measuring the number of QRS complexes within that 6-second strip. So you can see on the bottom picture here, there are 7 QRS complexes. So we're going to take that number, 7, and multiply it by 10, because again, we have 6 seconds going here, and there are 60 seconds in a minute. So if we multiply what we get in 6 seconds by 10, then we get our heart rate, which in this case is 70 beats per minute. So now let's look at the cardiac conduction system, which is what's responsible for generating and transmitting electrical impulses that control the heart's rhythm and contraction. The conduction pathway starts with the sinoatrial node, or the SA node, and this is known as the heart's natural pacemaker. It's located in the right atrium, and it sets the heart rate between 60 and 100 beats per minute. The SA node initiates the electrical impulse that spreads through the atria, which triggers atrial depolarization or atrial contraction, which is what's represented by the P wave on an ECG. Next, the impulse is going to travel to the atrioventricular node, or the AV node, which is located between the atria and the ventricles. The AV node briefly delays the electrical signal, which allows the atria to contract fully and push blood into the ventricles. This delay is represented by the PR segment on the ECG, and it's very important for optimizing cardiac output. This atrial contraction is also referred to as the atrial kick. From the AV node, the impulse then moves to the bundle of His, which then splits into the right and left bundle branches. These branches transmit the signal rapidly down through the ventricles. And finally, the impulse will reach the Purkinje fibers, which are located along the inner walls of the ventricles. And these fibers are what ensure that the ventricles contract in a coordinated and an efficient manner, which produces the QRS complex that we see on the ECG. So when this conduction system is working properly, the heart beats in a normal, coordinated rhythm. However, dysrhythmias can also occur whenever there is a disruption or a delay in this pathway due to things like diseases, electrolyte imbalances, or medication effects. So as nurses, it's very important that we understand these electrical processes so that we can recognize and respond to abnormal rhythms. So now let's talk about the electrophysiological properties of cardiac cells, which regulate the heart's ability to generate and transmit electrical impulses. So these properties are very important for maintaining normal heart rate and rhythm. So there are 4 key properties that allow the heart to function as an efficient pump. First, we have automaticity. So this is the pacing function of the heart. It refers to the ability of the cardiac cells to generate electrical impulses spontaneously and repetitively. So normally the SA node is responsible for this, but in cases of things like ischemia, electrolyte imbalances, hypoxia, or drug toxicity, other cardiac cells can take over, which can cause a dysrhythmia. Our second property is excitability. So this is the ability of non-pacemaker cells to respond to an electrical impulse. Depolarization or contraction occurs whenever the normally negative cardiac cells develop a positive charge, which allows electrical conduction to continue through the heart. Third, we have conductivity. This is the ability to transmit an electrical impulse from one cardiac cell to another. The impulse spreads very rapidly through the heart in a wave-like pattern, which produces the P wave and the QRS complex that we see on an ECG. Disturbances in conductivity occur whenever conduction is too fast, too slow, it's blocked, or it follows an abnormal pathway, all of which can cause a dysrhythmia. Lastly, we have contractility, and this refers to the mechanical activity of the heart. So once an electrical impulse reaches the atrial and the ventricular muscle cells, they contract, which generates enough pressure to push blood forward through the heart and into circulation. So altogether, these 4 properties just ensure that the heart functions as an efficient electrical and mechanical pump. However, when one or more of these properties gets altered, then we have an increased risk for dysrhythmia, which can compromise our cardiac output and our patient stability. So now let's focus for a second on automaticity, which again is the heart's ability to generate an electrical impulse without any external stimulation. Different areas of the cardiac conduction system have built-in pacemaker rates, and the site that controls the rhythm depends on which area is firing the fastest. So again, the sinoatrial node, which is again the natural pacemaker of the heart, located in the right atrium, normally fires at a rate of 60 to 100 beats per minute. This is what maintains a normal sinus rhythm, which we'll talk about later, in a healthy heart. If for some reason the SA node fails, then the atrioventricular node, or AV node, then takes over. The AV node fires at a slower rate of 40 to 60 beats per minute, which produces what's known as a junctional rhythm. In these rhythms, there's no visible P wave on the ECG because the impulse originates from the AV node rather than the SA node. If both the SA node and the AV node fail, then the His Purkinje system, which includes the bundle branches and the Purkinje fibers, can initiate impulses. However, this occurs at a dangerously slow rate of 20 to 40 beats per minute, and this is called a ventricular rhythm. Since the ventricles are now setting the pace, these rhythms are typically ineffective and they don't maintain enough cardiac output, which oftentimes requires immediate medical intervention, such as the placement of a pacemaker or emergency medications. So understanding which pacemaker site is controlling the heart is very important to be able to identify different dysrhythmias so that we can know whenever the heart is failing to maintain an adequate rhythm. All right, so at this point, you've heard me mention different waves and complexes and segments and intervals, all that make up a normal ECG tracing. So understanding each of these different components will help you correlate the electrical activity on an ECG with what's actually happening inside the heart. So we're going to go over all of these together. Don't worry, we're going to cover each one a little more in depth in the slides that follow. But first, starting with our ECG complexes. And to start, we have the P wave, and this is the start of our cardiac conduction cycle. So the P wave represents atrial depolarization, meaning the electrical impulse has traveled through the atria, causing them to contract. Then we have the QRS complex, and this represents ventricular depolarization, which is when the ventricles contract to pump blood to the lungs and to the rest of the body. The T wave represents ventricular repolarization, or the recovery phase when the ventricles reset for the next heartbeat. The U wave is not always present, but whenever it is seen, it can indicate an electrolyte imbalance, especially hypokalemia. Now let's talk about our ECG segments. So first we have the PR segment. This is the flat line between the end of the P wave and the start of the QRS complex. So it represents the time the impulse is delayed in the AV node before traveling to the ventricles. Then we have the ST segment. And this is a very important indicator of cardiac health. It represents early ventricular repolarization. So elevation or depression of this segment can mean that we've got some myocardial ischemia or a myocardial infarction. We really look at this for when we think someone may be having a heart attack. Also, getting into our ECG intervals now, and these are also very important. So the PR interval is measured from the start of the P wave to the beginning of the QRS complex. It represents the time for atrial depolarization and conduction through the AV node. A normal PR interval is going to be 0.12 to 0.20 seconds. So a normal PR interval shouldn't be any longer than one large square. Next, we have the QRS duration. So this measures how quickly the ventricles depolarize. A normal QRS duration is typically less than 0.12 seconds. A prolonged QRS could indicate that there is a bundle branch block or a ventricular conduction delay. The QT interval represents the total time for ventricular depolarization and repolarization. It's measured from the beginning of the Q wave to the end of the T wave. A prolonged QT interval can be very dangerous because it can lead to a type of ventricular tachycardia, which is called torsades de pointes. So a couple of key takeaways from this slide here. We always want to correlate the ECG components with the patient's clinical presentation. Changes in waveforms, intervals, or segments can indicate things like ischemia, an electrolyte imbalance, conduction disorders, or even a life-threatening dysrhythmia. So if an ECG tracing appears irregular, we always want to assess the patient first. Don't rely solely on the monitor. All right, so now let's focus on that P wave, which represents atrial depolarization, or the electrical activation of the atria, which causes them to contract. So this is the first visible deflection on an ECG, marking the start of each heartbeat. When an electrical impulse is generated by the SA node, it spreads across both atria, stimulating them to contract and push blood into the ventricles. This is the mechanical response to the atrial depolarization. So the appearance of the P wave can vary depending on the lead placement and where the electrical impulse originates. In a normal sinus rhythm, the P wave should be smooth, rounded, and consistent in shape across the ECG strip. If the P wave changes in shape or it becomes inverted or absent, then this may indicate that the impulse is not originating from the SA node, but rather from an ectopic focus, which is somewhere else in the atria. And we'll talk about what this is a little bit later on. But we see this in different atrial arrhythmias like AFib or A-flutter, or what we call PACs, which are premature atrial contractions. But by analyzing the P wave characteristics, we can determine whether the atria are depolarizing normally or if we have an abnormal rhythm that's present. All right, so now let's take a look at the QRS complex, which is one of the most important waveforms on the ECG. So the QRS complex represents ventricular depolarization, which triggers ventricular contraction or systole. So this is the most critical phase of the cardiac cycle because it propels blood out of the heart, either to the lungs via the right ventricle or to the rest of the body from the left ventricle. So let's talk about the different components of the QRS complex. First, we have the Q wave. This is the first negative deflection before the R wave. It's not always present, but when it's seen, it represents the initial depolarization of the ventricular septum. A deep or a wide Q wave might indicate that we have some myocardial necrosis or heart muscle damage. Next, we have the R wave. So this is the first positive deflection of the complex, and it represents the main depolarization of the ventricles. It's typically the tallest part of the waveform. And next, or last, we have the S wave. This is the negative deflection that follows that R wave, and it represents the final phase of ventricular depolarization. So now let's talk about the QRS duration and its clinical significance. So the QRS duration measures how long it takes for both ventricles to depolarize. It's measured from the start of the Q wave, or the R wave if there's not a Q wave, to the end of the S wave at the J point. So a normal QRS duration is 0.06 to 0.12 seconds, which is about 1.5 to 3 small boxes on the ECG paper. If the QRS complex is widened beyond that 0.12 seconds, then this suggests that we have a delayed ventricular conduction, which might occur in certain conditions like ventricular rhythms or hyperkalemia. So since the QRS complex represents the contraction of the ventricles, it directly correlates with cardiac output and perfusion. Any significant delay or abnormality in the QRS complex can mean that there is a serious cardiac dysfunction, including things like heart failure, a conduction disorder, or ischemia. So now let's talk about the T wave. And this represents ventricular repolarization, or the recovery phase of the ventricles. So after the ventricles contract, they need time to reset electrically before the next heartbeat. So again, this process is known as repolarization. It allows the heart muscles to return to that resting state so that they can fire again when the next impulse arrives. So mechanically, this corresponds to ventricular diastole, whenever the ventricles relax and fill with blood. So let's talk about the normal characteristics of our T wave. So the T wave always follows the S wave, and it's usually rounded and smooth. Its amplitude varies, but it shouldn't exceed 0.5 millimeters in the limb leads or 10 millimeters in the precordial leads, which is V1 through V6. The deflection of the T wave depends on the lead that's being viewed. It's typically upright in leads 1, 2, and V3 through V6, but it may be inverted in AVR. And don't get confused about this. We'll talk about these different lead names later. So now let's talk about the clinical significance of the T wave abnormalities. So as you guys know, a tall, peaked, or tinted T wave can indicate that we have hyperkalemia or even myocardial ischemia. A flattened or inverted T wave may be seen with myocardial ischemia and electrolyte imbalances like hypokalemia or hypocalcemia, or it may be due to certain medication effects. A U wave, if present after the T wave, can be a sign of hypokalemia or another electrolyte imbalance as well. So since the T wave reflects the heart's recovery phase, any abnormality should be carefully evaluated, especially in patients who have heart disease, any electrolyte imbalances, or those who are taking medications that might affect cardiac conduction. All right, so this is just an image that kind of breaks down all of the different components of the ECG that we just talked about. So here we can see a representation of how the electrical activity of the heart corresponds with the actual mechanical function, or what's actually happening in the heart, as well as how these phases occur on the EKG. So breaking down these EKG or ECG phases. So again, first we have the P wave, which is atrial depolarization. So again, this is the first phase in the cardiac cycle. It begins whenever the SA node fires, which sends that electrical impulse across the atria, triggering that atrial contraction, which pushes blood into the ventricles. So again, on the ECG, we see this represented as the P wave. And again, it's typically round and smooth. Next, we have our QRS complex, which is representative of ventricular depolarization. So this is when the electrical impulse moves through the AV node, through the bundle of His and the Purkinje fibers, causing the ventricles to contract and eject blood to the lungs or to the body. So again, this is shown as the QRS complex. Again, it's the largest and strongest waveform that we see on the ECG, representing the heart's most forceful contraction. And third, here we have ventricular repolarization, which is the T wave. So once the ventricles contract, they need to reset before the next heartbeat. Again, this recovery phase is called repolarization, and it allows the ventricles to fill with blood. The T wave represents this phase, and again, it's usually smooth and it's upright. Any abnormalities that we see in the T wave shape or its height can mean that we've got ischemia, some electrolyte imbalances, or we may have some different medication effects. So some key takeaways here, depolarization just means we're in our contraction or a systolic phase. The way I remember this is systolic is the squeeze phase. So we're contracting, we're squeezing that blood forward. And then we also have repolarization, which is that relaxation or diastole period, which allows the heart to relax and refill. All right, so now let's take a closer look at the PR interval, which is a very key measurement on the ECG that reflects how long it takes for an electrical impulse to travel from the SA node down to the atria, reach the AV node, and move into the ventricular conduction system, starting the QRS complex. So let's break down the PR interval. So the PR interval begins at the start of the P wave, and it ends at the start of the QRS complex. It represents the time that's required for atrial depolarization, as well as that slight delay that occurs at the AV node before the impulse is transmitted to the ventricles. So this delay is very important because it allows the atria to contract fully and push blood into the ventricles before they can contract. So now let's talk about the differences between the PR segment and the PR interval. So the PR segment is that flat isoelectric line between the end of the P wave and the beginning of the QRS complex. So this represents the time the impulse is delayed in the AV node before continuing to the ventricles. So the PR interval includes both the P wave and the PR segment, which measures the total amount of time for atrial depolarization and through the AV node conduction. So now let's talk about clinical significance. So a normal PR interval measures 0.12 to 0.20 seconds, which is 1 large box or 5 small boxes on the ECG paper. A prolonged PR interval suggests that there is a delay in AV conduction, which may indicate that we have a atrioventricular block or there is some sort of conduction system disease. A shortened PR interval may suggest that we have an abnormal accessory conduction pathway, which is what's seen in conditions like Wolff-Parkinson-White. So since the PR interval helps us assess impulse transmission speed, any abnormality needs to be evaluated in the context of the patient's heart rate, their symptoms, and their overall condition. So understanding that PR interval and how it can change is especially important when we start to learn about AV heart blocks, which is covered in level 4. All right, so now let's discuss that ST segment, which is a very important ECG component that reflects early ventricular repolarization, or the initial phase of the ventricles resetting after contraction. So what is the ST segment? So the ST segment begins at the J joint, which is where the QRS complex ends and extends to the beginning of the T wave. So under normal conditions, the ST segment is isoelectric, meaning that it sits on that baseline without any elevation or without any depression. The length of the ST segment can vary just depending on heart rate, electrolyte levels, and different medications. So why is the ST segment important? It's not a part of cardiac rhythm recognition per se, but the ST segment is very critical to identify cardiac ischemia and cardiac injury. So whenever we have elevation of the ST segment, this is a hallmark sign of an acute myocardial infarction, or what's called a STEMI, which is ST elevated myocardial infarction. So an elevation of at least 1 millimeter above baseline in 2 or more leads can suggest that we have an acute heart attack. And so obviously this patient who has this requires immediate intervention. Now, on the other hand, if we have ST segment depression, this can indicate that there's some sort of myocardial ischemia or even digoxin toxicity. So a depression of at least 0.5 millimeters below the baseline can suggest that we have reduced blood flow to the heart, which obviously requires further evaluation as well. So now let's talk about the clinical implications for nurses for the ST segment. So again, recognizing that ST elevation helps to identify a life-threatening cardiac event, which prompts our emergency treatment. ST depression can indicate, again, ischemia, and it needs to be evaluated alongside the patient's symptoms and risk factors. Sometimes if the ischemia occurs or continues to occur, then we end up seeing ST elevation, which, as we know now, is a sign of an acute heart attack. So we always want to compare the ST segment changes with the patient's clinical presentation. So symptoms like chest pain, diaphoresis, or shortness of breath can help us to confirm that the patient's having a cardiac event. All right, so now let's talk about the QT interval, which represents the total time that's required for ventricular depolarization and repolarization. So what is the QT interval? The QT interval is going to be measured from the beginning of the Q wave to the end of the T wave. It reflects how long it takes for ventricles to contract and fully recover before the next heartbeat. A normal QT interval ranges from about 0.36 to 0.44 seconds. But this is going to vary depending on age, gender, and the heart rate. A slower heart rate can lengthen the QT interval, and a faster heart rate can shorten it. So why is the QT interval important? Well, while it's not really needed to determine the cardiac rhythm, it plays a big role in detecting any potential life-threatening arrhythmias. So a prolonged QT interval can be caused by different electrolyte imbalances like low potassium, calcium, or magnesium, and different medications like certain antibiotics, certain antiarrhythmic medications, some antidepressants, and some antipsychotic medications. So a prolonged QT interval can increase the risk of a dangerous ventricular arrhythmia called torsades de pointes. And this is a polymorphic ventricular tachycardia, which I know is lots of big words I'm throwing at you, but rest assured we'll talk about some of this later on in this lecture. But it can lead to a cardiac arrest. So let's talk about our clinical implications for the nurse with our QT interval. So we want to monitor the QT interval in our patients who are taking some of the medications that are known to prolong it. We need to be aware of electrolyte disturbances that could increase the risk of torsades de pointes. If a prolonged QT interval is detected, then we need to report it to the provider to prevent any potential arrhythmias. All right, so here on the slide, we've got a picture which gives us a very comprehensive view of all the things we just talked about, which is how electrical activity on an ECG correlates, again, with what's actually happening within the heart, or that mechanical heart function. And this is so important. You have to understand how the electrical tracings correlate to what's actually happening in the heart, because that gives us a really good understanding of how any abnormalities or dysrhythmias are affecting our patient. So we're going to break down each of these ECG phases. Again, we've already talked about them, so this should just serve as a review. So first we have the P wave, which represents atrial depolarization, which is that electrical impulse that moves through the atria, causing them to contract and push blood into the ventricles. So this corresponds with atrial systole, or the squeezing of the atria. Next is the PR interval, and again, this is normally 0.12 to 0.20 seconds. The PR interval measures the time that it takes for the electrical impulse to travel from the SA node through the atria and to reach the AV node. Anytime that there is a prolonged PR interval, we may be looking at a type of heart block, which is a first-degree heart block. Next, we have ventricular depolarization, which is represented by the QRS complex, and this is normally 0.04 to 0.12 seconds. So the QRS complex represents that rapid conduction of impulses through the ventricles, leading to the ventricular contraction or ventricular systole. A prolonged QRS duration may suggest that we have a bundle branch block or some sort of ventricular conduction delay. Next, we have the T wave, and this represents ventricular repolarization or ventricular recovery, or the resetting of that electrical charge so the heart can beat again. Anytime we have an abnormal T wave, we might be seeing things like ischemia, an electrolyte imbalance, or an effect of a medication. Next is the QT interval, which is 0.36 to 0.44 seconds. And again, this measures that total time it takes for ventricular depolarization and repolarization. And then we also have the U wave. If it's present, it's not always seen, but if it is there, then it may be reflecting that there is some repolarization of ththose Purkinje fibers or the bundle cells. A very prominent U wave may mean that we have hypokalemia. All right, so now let's go through that step-by-step process of ECG rhythm analysis. So whenever we follow this method, we can systematically evaluate a heart's electrical activity and detect any abnormalities in the rate, the rhythm, the conduction, or whether or not there's any ischemia present. So we have 8 key steps to determine an ECG rhythm. So first is step 1, and that's to determine the heart rate. The 6-second strip method that we talked about earlier is going to be the quickest way to evaluate the heart rate. So again, with this, we're going to count the number of QRS complexes in 6 seconds, and then we're going to multiply that number by 10 to get the beats per minute. A normal heart rate is going to be 60 to 100 beats per minute. Bradycardia is going to be less than 60 beats per minute, and tachycardia is going to be more than 100 beats per minute. Step 2 is to determine the heart's rhythm. So we're going to assess atrial and ventricular regularity. So we're going to measure the P to P intervals, which is the atrial rhythm, and the R to R intervals, which is indicative of our ventricular rhythms. So a regular rhythm has consistent and evenly spaced ventricles, meaning that the space between each R wave, the R to R intervals, is the same amount of time between each one. Now, if we have an irregular rhythm, or maybe even regularly irregular, then this is when we have like R intervals that are occurring at different time intervals. So instead of having that same consistent amount of time between each R to R interval, they can vary. Some are going to be really short between one R to R, and then between the next R to R interval, it may be even longer. Again, it's just an irregular heart rate. So, you know, if you're listening to someone's heart rate, if you hear, you know, lub-dub, 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 it's the same amount of time between each heartbeat. That's an irregular, or that is a regular rhythm. Now, if you hear lub-dub, 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 then you know that that's irregular, because the amount of time between the R waves, or what you hear as far as ventricular systole, is irregular. It has differing amount of times between them. So moving on to step 3, and this is where we analyze the P wave. So a P wave, again, represents that atrial depolarization. So we want to ask ourselves, are there P waves present? Yes or no? Do the P waves occur before each QRS complex? And do all P waves look similar, and are they upright and rounded? and the leads that they need to be, such as leads 2, 1, 2, and AVF. If there is an abnormal P wave, then we may have a ectopic atrial focus, meaning that the impulse is not actually originating from the SA node. So remember, if there is a P wave present and it looks normal, then typically that's going to mean that we've got some sort of a sinus rhythm occurring because it's occurring from that sinoatrial node. So step 4 is to measure the PR interval, which again, 0.12 to 0.20 seconds is a normal PR interval. So again, this is the time that it takes for an impulse to travel from the SA node through the AV node into the ventricles. Step 5 is to measure the QRS duration, which again, this is typically 0.04 or 0.06 to 0.12 seconds. So again, the QRS complex represents ventricular depolarization or contraction of the ventricles. So we want to check to see if all QRS complexes look the same, that they have the same morphology, meaning again that they look the same, showing that they are all coming from the same focus or same electric area. Step 6 is going to be to examine the ST segment. So the ST segment represents early ventricular repolarization, and it should be at that isoelectric or flat line. Again, ST elevation can suggest that we have an acute myocardial infarction, whereas ST depression may indicate that we've got some ischemia or digoxin toxicity. Step 7 is that we want to assess the T wave. So again, this represents ventricular repolarization. It should be upright and rounded in most leads. A tall peak T wave, as we know, suggests that we have some hyperkalemia occurring. And an inverted T wave may mean that we have some ischemia or there may have been a previous myocardial infarction. Our last step is to measure the QT interval. So the QT interval represents the total time for ventricular depolarization and repolarization. So final thoughts here, by following these 8 steps, we can systematically interpret an ECG and to detect any potential dysrhythmias. Remember, we always want to correlate what we see on the ECG with the patient's clinical symptoms. A patient's presentation is just as important as the ECG strip itself. Okay, so now let's take a look at what we consider to be a normal, healthy heart rhythm. And this is known as a normal sinus rhythm. So this is the baseline for comparing any other heart rhythms. So understanding this pattern is key to interpret an ECG accurately. So a normal sinus rhythm originates from the sinoatrial node or the SA node, which again is the heart's natural pacemaker. So this means that the impulse starts in the right atrium and it follows that normal conduction pathway, ensuring that we have a steady and coordinated heartbeat. But how do we know if what we're looking at is actually a sinus rhythm? Well, there are 5 key characteristics of a normal sinus rhythm, and you'll want to check for these every time that you analyze an ECG. So again, these are going back over those steps that we just talked about. So first is getting the heart rate. So an atrial and ventricular rates for normal sinus rhythm should be between 60 and 100 beats per minute. This is a normal resting heart rate range for adults. Then we're going to look at the rhythm. So both the atrial and the ventricular rhythms should be regular. So this means that the P to P interval and the R to R interval are consistent throughout the strip. Third, we're looking at that P wave. So the presence of a normal P wave before each QRS is what confirms that the rhythm originates in that SA node. So these P waves should be consistent in their shape and they should be evenly spaced. Then we look at the PR interval. So this, again, measures the time that it takes for the impulse to travel from the SA node through the AV node and into the ventricles. So a normal PR interval is 0.12 to 0.20 seconds. And again, it should remain constant across the ECG strip. Next is the QRS complex, or the QRS duration, which again is representative of ventricular depolarization. And this should be less than 0.12 seconds. This tells us that the electrical conduction through the ventricles is occurring efficiently. So when we put all of this together, A rhythm that meets all 5 criteria is considered a normal sinus rhythm. So why is this important? Well, because once you know what normal sinus rhythm looks like, you'll be able to very quickly recognize when something's off. Variations in heart rate, irregular rhythms, missing or abnormal P waves, or prolonged PR and QRS intervals can all indicate that there's an underlying condition that requires further assessment. So remember, whenever we're analyzing an ECG, we always want to check for the rate, the rhythm, the presence of P waves and whether they're normal or not, the duration of the PR interval, and we want to look at the QRS duration, the QRS complex as well. If everything aligns with what we see here on this slide, then we're looking at normal sinus rhythm. All right, so now let's talk about a sinus arrhythmia. And the word arrhythmia might make you think that this is an abnormal heart rhythm, but in this case, it's actually just a normal variation of sinus rhythm. So sinus arrhythmia is most commonly seen in healthy adults, and it's typically going to be influenced by changes in intrathoracic pressure while a patient is breathing. So here's what happens. When you inhale, the heart rate can slightly increase, and when you exhale, it may slightly decrease. So this rhythmic fluctuation is controlled by the autonomic nervous system, and it's typically benign. So how do we identify a sinus arrhythmia on an ECG? So first, the rate remains within that normal range of 60 to 100 beats per minute. The P waves are going to look consistent, and they're going to occur before every QRS complex, just like in a normal sinus rhythm. The PR interval and the QRS duration are going to be normal, and they're also going to be constant. But the key distinguishing feature is the irregularity of the rhythm. So the P to P and the R to R intervals may vary, with a difference of at least 0.12 seconds, or 3 small boxes on that ECG strip, between the shortest and longest intervals. So while a respiratory sinus arrhythmia is common and usually harmless, sinus arrhythmia can also be non-respiratory and triggered by certain medications like digoxin or even morphine, which can enhance that vagal tone and slows the heart rate. So in these cases, the irregularity is not related to breathing. So if you see a sinus arrhythmia on an ECG, we need to consider the patient's clinical presentation. If they're young and healthy, this is likely going to be a normal finding. However, if this patient is on medications that affect heart rate, or they have an underlying cardiac concern, then we may need to have some further evaluation. All right, so now let's talk about 2 major categories of dysrhythmias: Brady dysrhythmias and tachydysrhythmias. And these terms refer to heart rates that are either too slow or too fast, both of which can significantly impact a patient's hemodynamic stability. So I want you to keep in mind as we go through what's actually happening as far as hemodynamic stability in heart rates that are too fast or too slow, and take this information that we learned on this slide and translate it to some of our other arrhythmias or dysrhythmias that we're going to talk about when the heart rate is too fast or too slow, so that you understand what's actually happening within the heart and how it impacts our cardiac output. So let's get started by talking about Brady dysrhythmias. So this is any rhythm where the heart rate is less than 60 beats per minute. So while a slow heart rate can sometimes be beneficial, it can reduce the myocardial oxygen demand, and it can potentially allow for more adequate coronary perfusion. It can also be very problematic. If the heart rate becomes too slow, then coronary perfusion pressure can decrease, which leads to insufficient cardiac output and a low blood pressure. So this can cause myocardial ischemia, dysrhythmias, hypotension, and even heart failure. So the key takeaway here is that not all bradycardia is harmful, but whenever it causes poor perfusion, then intervention is going to be required. Tachydysrhythmias, on the other hand, this is where the heart rate exceeds 100 beats per minute. These are particularly concerning in patients who have coronary artery disease because they shorten the diastolic time. So that reduces the amount of blood that flows into the heart. So initially, a faster heart rate can increase our cardiac output and our blood pressure. But if the heart rate remains elevated, then the ventricular filling time is going to decrease. So we're going to see a decrease in stroke volume, as well as a decrease in cardiac output and a decrease in coronary perfusion pressure. Over time, the heart's workload is going to increase, and so does the myocardial oxygen demand, and this is not going to be sustainable. So patients who have tachydysrhythmias may report some signs and symptoms like palpitations, which is a sensation of their heart racing or skipping beats. They may have chest discomfort, which may indicate that we've got some myocardial ischemia going on. They may have some restlessness or anxiety, especially as the body is struggling to maintain an adequate perfusion. They may have pale, cool skin, which suggests that we have a compromised circulation. And they may also have syncope or fainting due to the hypotension. So both Brady and tachydysrhythmias can progress to more serious complications, including things like heart failure. So our key takeaways here: dysrhythmias are going to be categorized based on their state of origin, whether from the SA node, the AV node, or the ventricles, and how they affect rate and rhythm. Some are going to be benign, while others can be life-threatening, especially if they cause a decrease in cardiac output in an impaired tissue perfusion. So being able to recognize what's actually happening to the heart and to our patient whenever they have a too fast or too slow heartbeat, too fast or too slow of a heartbeat, that's going to be very important to know what we need to do to help them reach efficient outcomes. All right, so before we really dive into all of the different dysrhythmias that are out there, we need to talk about the care of a patient who has a dysrhythmia. So dysrhythmias can have very serious consequences. They can range from just mild discomfort to life-threatening complications. And as nurses, our role is to monitor, to assess, and to intervene effectively so that we can maintain that hemodynamic stability and prevent any complications. So we're going to go through some of the key components of patient care. First is going to be vital sign monitoring and assessment. So we begin with frequent vital sign assessment at least every 4 hours or as needed. Continuous monitoring is very important because sometimes those subtle changes in heart rate, heart rhythm, blood pressure, or even the respiratory status can indicate that we've got a worsening dysrhythmia on our hands. We also need to evaluate and document the patient's response. So not all dysrhythmias are going to be symptomatic. So this is why recognizing early warning signs is so important. Second, we need to look at patient education and chest pain assessment. So encouraging patients to report chest pain immediately is critical. Chest pain can indicate that we have some sort of myocardial ischemia, which can progress to a myocardial infarction or a heart attack if it's not treated quickly. So when we're assessing chest pain, we need to consider the location of the pain. Is it central in the middle of the chest? Does it radiate to the arms or to the jaw? We need to look at the intensity of the pain. Is it mild, moderate, or severe? The duration, how long has the chest pain lasted? And again, going back to radiation, does it move anywhere, especially the arms, the jaw, and sometimes even the back? And then we need to look at any precipitating or alleviating factors. What makes this better or worse, and what other symptoms come along with the chest pain? Third, we need to look at the circulatory and respiratory assessment. So we need to assess peripheral circulation, including checking for pulse quality, looking for any edema, checking capillary refill and skin color and temperature. Poor circulation can mean that we have a decreased cardiac output due to the dysrhythmia. Respiratory distress is another big concern, so we want to watch out for things like shortness of breath, labored breathing, or rapid respirations, because dysrhythmias can cause pulmonary congestion or a decrease in oxygenation. Fourth, we're looking at medication and intervention management. So many patients will need antidysrhythmic therapy, which can include medications like beta blockers, calcium channel blockers, or different antiarrhythmics. They may require cardioversion, especially for our tachydysrhythmias, and sometimes even defibrillation for those life-threatening ventricular rhythms that we're going to talk about later. So nurses play a big role in monitoring and documenting the responses to these interventions so that we can ensure that we have therapeutic effectiveness and patient safety. Next, we have laboratory and activity monitoring. So monitoring those cardiac enzymes, which are like lab values, and their electrolytes is going to be very important. We know that potassium, magnesium, and calcium imbalances can all contribute to dysrhythmias. We also want to help regulate the patient's activity level, making sure that they have scheduled rest periods so that we can prevent things like fatigue, which can worsen a dysrhythmia. And lastly, we need to look at stress reduction and emotional support. So emotional and psychological support is a very key part of our physical care of these patients. Anxiety and stress can exacerbate a dysrhythmia. So we really need to encourage stress reduction techniques like deep breathing, guided imagery, and even just simple reassurance to these patients. So big takeaway here, managing dysrhythmias requires a very comprehensive nursing approach. We need to combine vigilant monitoring, timely interventions, and holistic patient support. All right, so getting started with some of our dysrhythmias. And first we have our sinus dysrhythmias. So again, that SA node in the right atrium is going to be the pacemaker in all sinus dysrhythmias. Innervation from the sympathetic and the parasympathetic nerves is normally in balance to ensure that we have a normal sinus rhythm. An imbalance increases or decreases the rate of SA node discharge, either as a normal response to things like activity or physiologic changes, or as a pathologic response to a disease. So sinus tachycardia and sinus bradycardia are two of the most important types or most common types of a sinus dysrhythmia. And we're going to talk about those on the next few slides. All right, so let's start by talking about sinus tachycardia. And this is a condition where the heart rate goes above 100 beats per minute due to an increased rate of SA node discharge. So this can be a normal physiological response, or it may indicate that there's an underlying problem. So now first let's talk about how we can identify sinus tachycardia on an ECG strip using that analysis method we talked about before. So first we look at the heart rate. We can see that the heart rate is going to be greater than 100 beats per minute. Next we look at the rhythm regularity. So the R to R intervals are going to be consistently spaced, so that indicates that we have a regular rhythm. Next we look at the P waves. So each QRS has a P wave that comes before it that's normal. So this confirms that our impulse originates from the SA node, which tells us that we have a sinus rhythm. So now we know that we have a sinus tachycardia. So now let's break sinus tachycardia down a little bit. So what causes this to happen? Well, there are two primary mechanisms that are at play here. We have the sympathetic nervous system, which can be stimulated, and we also have vagal inhibition. So in simple terms, the body's fight or flight response kicks in, or there is a reduced influence of the parasympathetic nervous system. So let's talk about some common triggers. So one of the most common triggers is going to be an increase in the sympathetic stimulation. So we see this with like physical activity, pain, anxiety, fever. We also see this with things like anemia and hypoxemia and hyperthyroidism. All of these increase that sympathetic nervous system stimulation, which increases the heart rate. Different drugs can cause sinus tachycardia, things like epinephrine, even caffeine, nicotine, cocaine, and thyroid medications. Also, sinus tachycardia may be due to it being a compensatory response to a low blood pressure or low cardiac output. We see this in things like dehydration, hypovolemic shock, myocardial infarction, sepsis, and heart failure. So how does sinus tachycardia affect the heart? So initially, sinus tach is going to increase our cardiac output and our blood pressure. However, if the heart rate remains high, then it's going to eventually reduce that relaxation or diastolic filling time. It's also going to decrease coronary perfusion, and it's going to increase the myocardial oxygen demand. So over time, this can really compromise cardiac function, and so it leads to symptoms like fatigue and dizziness, palpitations, shortness of breath, and sometimes even chest pain due to that reduced oxygen delivery to the heart muscle. So how do we manage sinus tachycardia? Well, first we need to treat the underlying cause. So if it's due to something like anxiety, then we may need to use anti-anxiety techniques or medications to help relieve the anxiety. If the sinus tach is due to dehydration, then we may need to administer fluids. If we have a sinus tach due to sepsis, then sometimes vasopressors may need to be used to maintain the blood pressure. Blood loss is also a common cause, so to treat this, we would consider giving blood products or even albumin to restore that blood volume. We need to be very mindful that certain breathing treatments, especially albuterol, can induce a tachycardia. And then again, some medications. We need to watch some of these medications. So some drugs like hydralazine, which is a type of calcium channel blocker, needs to be held if the heart rate is above 90 beats per minute to prevent a worsening tachycardia. So some key nursing considerations for sinus tach. We want to monitor for signs of poor perfusion, such as fatigue, weakness, a decrease in urine output, which just means there's a decreased cardiac output, so we've got decreased perfusion to the kidneys. So we see that decreased urine output. We also want to monitor for things like hypotension and restlessness. Again, all are signs of poor perfusion. We're going to assess the ECG for any changes, especially looking at that T wave and the ST segment, making sure that there's no myocardial ischemia happening. We may need to encourage bed rest, especially if the patient is symptomatic with low blood pressure. And we're going to educate our patients on avoiding stimulants like caffeine, alcohol, and nicotine. And we want to teach them to implement some stress management techniques. So the goal of treatment is really to bring the heart rate back to normal by addressing that root cause rather than just trying to slow it down with medications. So nursing interventions are very important in identifying the cause and providing the appropriate intervention to ensure that we have that optimal perfusion and cardiac function. Moving on to sinus bradycardia, which is a condition where the heart rate is less than 60 beats per minute due to a decreased sinoatrial node discharge. This rhythm can be completely normal in athletes and during sleep, but it can also be caused by excessive parasympathetic or vagal stimulation, or due to certain other pathological conditions. So first, let's talk about how we can identify sinus bradycardia on an ECG. So again, going back to that rhythm analysis method we talked about. First, we're going to look at the heart rate. We can see that it's less than 60 beats per minute. Typically in bradycardia, it's still going to be above 40 beats per minute, but less than 60 is what defines sinus bradycardia. Next, we look at the regularity of the rhythm. So our R to R intervals are consistently spaced, which means we have a regular rhythm. Next, we look at the P wave. So for each QRS complex, we can see that on the strip here, there is a P wave that comes before the QRS complex, and that P wave is normal. So this confirms that the impulse is originating from the SA node, so it is a sinus rhythm. So this is where we get sinus bradycardia. So sinus bradycardia can be a normal finding, like I said, in athletes or during sleep, but it can also be the result of vagal stimulation, different medications such as beta blockers or calcium channel blockers. It may be due to hypoxia or even hypothyroidism. It's differentiated from different types of heart blocks or junctional rhythms because we have that presence of the P wave before each QRS complex, and it is just has a gradual onset rather than a abrupt slowing of the heart rate. So first, let's talk about some of the different causes, and I know I just hit on some of the different causes, but let's go over some more. So first, we have one of the causes being increased vagal stimulation, and this can occur due to vomiting or suctioning, Valsalva maneuvers like bearing down, ocular pressure, or even severe pain, as well as a carotid sinus massage. Some different medical conditions can cause bradycardia, such as hypoxia and inferior wall myocardial infarction, different electrolyte imbalances, neurologic disorders, and hypothyroidism. There are some different medications that can slow conduction through the SA node, and this includes beta blockers, again, those medications that end in law, like metoprolol. Other medications are calcium channel blockers, and then we also have the medication digoxin, which can slow the heart rate as well. So now let's talk about the hemodynamic effects on the heart. So first, there are some potential benefits to sinus bradycardia. There is an increased coronary perfusion time, which means that the heart has more time to fill during diastole, and it reduces the myocardial oxygen demand, which can be helpful in some cases. However, there are some potential risks that can happen to our hemodynamic effects. So some of the potential risk is that we could possibly have a decrease in cardiac output due to the slower heart rate. Also, we could have a reduced coronary perfusion pressure, which leads to inadequate circulation. So some of the different signs and symptoms that we see with bradycardia. So a patient with sinus bradycardia may be completely asymptomatic, or they may present with things like syncope, which is fainting or having a blackout, dizziness or weakness, confusion, hypotension, diaphoresis, shortness of breath, and even chest pain. So when we've got a patient with sinus bradycardia, we want to look at our different interventions and our treatments. So first, we need to identify and treat the underlying cause. So if bradycardia is due to medications, we need to either stop or adjust them. And if the bradycardia is related to a hypoxia, then obviously we're going to provide oxygen therapy. If the patient is symptomatic with their bradycardia or they're unstable, then we need to initiate treatment. And the biggest treatment for this, following the American Cardiovascular Life Support Guidelines set forth by the American Heart Association, is to administer atropine IV. Atropine works to increase the heart rate so that the patient is no longer symptomatic or unstable. We can also provide IV fluids to help maintain blood pressure. And sometimes we may need to consider transcutaneous transvenous pacing, especially if the heart rate remains dangerously low. For really severe cases, a permanent pacemaker may be required. So just kind of a takeaway here, not all bradycardia is harmful, but whenever it leads to symptomatic hypotension or decreased perfusion, then immediate intervention is going to be required to stabilize these patients. All right, so now we're going to take a closer look at atrial dysrhythmias. And these are disturbances in the heart rhythm that originate in the atria rather than in the SA node itself. And what we see with these are changes in the P wave shape, which can indicate that we've got an abnormal impulse conduction within the atrial tissue. So there are several different types of atrial dysrhythmias. The most common ones that we're going to go over in the next few slides are premature atrial complexes, or PACs, supraventricular tachycardia, or SVT, atrial fibrillation, otherwise known as AFib, and atrial flutter. All right, so we're going to start by talking about premature atrial complexes. So we know that in a normal conduction pattern, the SA node is the primary pacemaker of the heart. It initiates each electrical impulse that travels through the myocardium to generate a contraction and relaxation. However, in a premature atrial complex, or PAC, the contraction is initiated from what's called an ectopic focus, meaning that it's a site that's outside of the SA node, which fires before the next sinus impulses do. So a PAC is not necessarily a dysrhythmia, whereas it's more so just an abnormality found on a EKG rhythm, such as normal sinus rhythm. A patient can be in normal sinus rhythm and have an abnormality of a premature atrial complex. So PACs are identifiable on an ECG by an early abnormally shaped P wave. This is because the impulse is originating from a different location other than the atria. So the P wave is going to look different from the normal sinus P waves. Also, PACs are usually going to be followed by a pause as the heart resets itself before the next beat. The QRS complex that follows a PAC is usually normal in its shape and duration because the ventricles will depolarize normally. So you can see here on the slide how to identify that PAC. So the second cardiac conduction cycle, you see that first one starting at the beginning of the ECG strip, you've got a normal P wave and a QRS. But then there's something funky, a little bit different about that next P wave, and it's happening a little sooner than we would expect. So it causes the QRS, or the ventricles, to contract, and so we see the normal QRS, followed by a little bit of a pause. Like I had said before, it kind of has a little pause so that the heart can reset itself after having this premature beat. And then you can see the heart rate starts back over in its normal sinus rhythm cycle there, up until about the 1, 2, 3, 4, the 5th beat, which has another PAC, or premature atrial contraction, which again is evident by that abnormally shaped P wave. So again, a PAC is not a dysrhythmia in itself. More so, it's just an abnormality within the rhythm. So now let's talk about what causes a PAC. So there are several potential triggers. Emotional distress or physical fatigue can be a trigger, as well as different stimulants like caffeine, nicotine, or even alcohol. Hypoxia or different electrolyte imbalances, different medical conditions like hyperthyroidism, COPD, and heart disease, and certain medications like digoxin and different anesthetic agents, all of which can be a potential triggering factor for a PAC. So most of the time, PACs don't cause any symptoms. A lot of people experience them and don't even know it. However, some patients may report that they have a sensation of palpitations or feeling like their heart is skipping a beat. Since PACs result in a reduced atrial filling time, cardiac output can be slightly decreased, which is why in some cases patients have symptoms like dizziness or even lightheadedness. So again, PACs themselves are not an actual heart rhythm, but rather they're just an event within an underlying rhythm. So like I said, a patient may have a normal sinus rhythm with occasional PACs. So now let's talk about how we can manage a PAC. No intervention really is needed, especially for isolated PACs in healthy individuals. If the PACs are frequent and they're associated with symptoms or progression to a more serious atrial tachydysrhythmia, then treatment might be necessary. So with this, we just want to treat the underlying cause. So if we've got heart failure, we need to treat the heart failure, or even if it's due to an electrolyte imbalance, we'll treat the electrolyte imbalance. We also want to reduce stress and fatigue, avoid any stimulants like caffeine, alcohol, and nicotine, and we may need to adjust some medications if that's necessary. So if PACs occur frequently and the patient is at risk for something like atrial fibrillation or another tachydysrhythmia, then an antidysrhythmic medication might be prescribed. So, all right, a few takeaways to kind of wrap up premature atrial complexes here. So again, these are common and they're often benign. They occur whenever there is an ectopic focus in the atria that fires prematurely, which again results in that early P wave that has an abnormal shape. They can be caused by stress, stimulants, electrolyte imbalances, or underlying conditions. Most patients are asymptomatic, but some patients may have palpitations. And our management is going to focus on treating that underlying cause rather than just treating the PAC itself. All right, so now let's move into supraventricular tachycardia, or SVT. And this is actually one of my favorite conditions to treat in the ER. So SVT is a condition where the atrial tissue is rapidly stimulated, and it leads to a heart rate between 100 and 280 beats per minute. That's really, really fast. In some cases, it can be even faster. So first, to understand what's happening, let's break down the name. So the name itself gives us clues about the condition. So supra means above. Ventricular refers to the ventricles. And tachycardia means a fast heart rate. So SVT originates above the ventricles, typically in the atria or even sometimes the AV node, and it leads to a very rapid heart rate. So let's talk about how we can recognize SVT on an ECG. So again, first we look at the heart rate. So here we're counting again those R waves, so those QRS complexes. A heart rate with SVT is typically going to be between 150 and 250 beats per minute. Again, sometimes it can be faster. The rhythm may be regular or it might be slightly irregular. Now we come to the P wave. So oftentimes, because this heart rate is going so fast, the P waves are going to be hidden in the preceding T wave, or they may appear abnormal. So again, it's so fast that sometimes we don't see that P wave, and you can kind of see here on the slide And what you see there, kind of right there, if you see it the beginning of the strip there, that's actually the T wave before the next QRS complex. Starting that. So sometimes it can be a little hard to tell if you don't know exactly what you're looking for. That's why looking at these strips over and over and over again, you'll get so much better at being able to recognize dysrhythmias. But anyways, yes, P waves are often going to be hidden in the preceding T wave on SVT. And the QRS complex is usually going to be normal in its normal duration, and it will always be present. So now let's talk about with SVT, what's actually happening in the heart. So SVT is usually caused by a re-entry mechanism. So this means that an electrical impulse gets caught in a loop within the atrial conduction pathways, which repeatedly re-stimulates the atria at a very rapid rate. So this rapid atrial stimulation results in the ventricles having to contract too quickly. So with this, because the ventricles are contracting too quickly, this reduces the amount of time the ventricles can relax and fill. Therefore, it's going to reduce cardiac output. And this is why patients often become very symptomatic with supraventricular tachycardia. So let's talk about some of the different causes and risk factors. So SVT can be triggered by overexertion or stress, deep inspiration, caffeine, nicotine, or stimulants, and certain conditions like Wolff-Parkinson-White, WPW syndrome, which oftentimes involves an extra electrical pathway in the heart. And sometimes it's just idiopathic. We don't really know exactly what causes SVT in certain individuals. It's actually kind of common to be seen in tall, thin males for whatever reason. They are at a slightly higher risk or have a slightly higher incidence of having SVT. So now let's talk about our clinical symptoms. What are we going to see in these patients? So because the heart rate is beating so fast and it doesn't have time to fill up properly, then we start to see decreased cardiac output. And with this, we see our patients reporting a fluttering or feeling they have a racing heart rate. They have palpitations, they have shortness of breath, they can have chest pain. A lot of times they get dizzy or have syncope. And so let's talk about why this is so important. So it's very important to differentiate SVT from other tachydysrhythmias like atrial fibrillation with RBR, which we'll talk about in a few minutes. So that's why getting a 12-lead ECG needs to be obtained as soon as possible so that we can confirm this diagnosis. All right, so now let's talk about how we care for our patients with SVT. So whenever a patient presents with SVT, we need to assess their symptoms very carefully. So a lot of patients experience, again, palpitations, chest pain, weakness, fatigue, shortness of breath, and sometimes even anxiety. If the heart rate is extremely fast for a prolonged period, then they can also have hypotension and syncope just due to that decrease in their cardiac output. In really severe cases, cardiovascular deterioration can happen and they start to have angina, heart failure, and sometimes can even lead up to cardiogenic shock. So if SVT resolves on its own, no intervention is typically going to be needed beyond removing whatever triggered it, such as caffeine, stress, or stimulants. However, if the rhythm does persist, then we move toward active management. So for patients who have recurrent SVT, meaning that they have it several times, then the preferred long-term treatment is going to be radiofrequency catheter ablation. So this procedure targets and it eliminates the abnormal conduction pathway that is causing the dysrhythmia so that we can prevent future episodes. Now for acute episodes, as far as how we manage this emergently, first we're going to start with vagal maneuvers. So vagal maneuvers such as having a patient bear down as if they're having a bowel movement, cough forcefully, or even sometimes a carotid sinus massage. That's a very rare technique because it has a lot of risk with it, but usually bearing down and coughing forcefully using those vagal maneuvers. And these work because they stimulate the parasympathetic nervous system to help slow conduction through the AV node. I personally have never seen vagal maneuvers work to treat SVT, but I've been in the ER and usually by the time they get to us, it's been going on for at least some amount of time. So if vagal maneuvers aren't effective, then that's when we escalate to medications. And here we use IV adenosine. And this medication acts as a reset button for the heart. So adenosine is given as a rapid IV push, and it's immediately followed by a normal saline bolus to ensure that it reaches the heart very quickly. When we give this medication, you need to warn patients in advance that they may feel a moment of heaviness in their chest, or they may get short of breath. A lot of times patients have said they felt like they got kicked by a mule. But while we're giving this and after it's administered, one thing that we're going to be doing, obviously, aside from monitoring our patient, we're going to be looking at the monitor. So with the administration of IV adenosine, we expect to see a brief period of asystole before the heart rate resumes a normal rhythm, usually only lasting a couple of seconds, and then hopefully the patient's underlying normal rhythm takes over. Sometimes it requires 2 doses of adenosine. Usually we give 6 milligrams the first time and then 12 milligrams with the second dose. So if adenosine fails, then synchronized cardioversion is our next step, especially if the patient's not stable or isn't stable. So with synchronized cardioversion, this delivers a controlled electrical shock to reset the heart's rhythm. So for unstable SVT, meaning the patient has severe hypotension, altered mental status, or signs of shock, then we're going to skip vagal maneuvers and adenosine, and we're going to proceed directly to synchronized cardioversion to restore that normal sinus rhythm. All right, so now let's talk about atrial flutter, which is a type of atrial tachydysrhythmia that originates from a single ectopic focus in the atrium. So this comes from one electrical charge focus starting point in the atrium that's not the SA node. So this rhythm is going to be recognized by these sawtooth-shaped flutter waves that are recurring and they're regular. So instead of seeing that normal pretty little P wave that we love so much, we actually see these sawtooth-shaped flutter waves in their place. So let's talk about what's happening in atrial flutter. So this ectopic focus, this place where we've got this electrical conduction starting, that's not the SA node. Remember, ectopic means somewhere other than where it's supposed to. So this ectopic focus within the atria fires at a very rapid rate, typically between 200 and 350 beats per minute. The AV node, though, acts as a gatekeeper. So it controls how many of these impulses actually get through to reach the ventricles. So in most cases, not all of these atrial impulses are conducted to the ventricles. If they were, the heart rate would be beating dangerously fast. So there are some cases where the impulses do get through, which leads to a really fast heart rhythm, but we're going to talk about more so with atrial fibrillation. So let's talk about how we can identify atrial flutter on an ECG. So first, again, we look at that heart rate as always. So we can count those R to R intervals or R complexes, R waves within that 6-second strip. So we've got 1, 2, 3, 4, 5, 6 that are on that strip there. So we know that that's a normal heart rate. But then we're going to move on to whether or not if we have a regular or irregular heart rhythm. So typically with a flutter, we see for the most part, regular rhythm, meaning again that the R waves are occurring at the same amount of time between each conduction. So the ventricular rate with atrial flutter is really going to depend on the conduction ratio, meaning how many beats, how many atrial impulses does it take before a ventricle impulse is conducted. So there's some example conduction ratios. We may have a 2-to-1 conduction where we've got 2 flutter waves to 1 QRS complex. We may have a 3-to-1 where there's 3 flutter waves per 1 QRS complex, or we may even have a 4-to-1 where there's 4 flutter waves, which is what we see here before each QRS complex. So If the conduction is consistent, then like I said, typically these are going to be regular. Sometimes they can be a little bit off and it may be irregular. But one of the biggest things is we're not going to have a really identifiable pretty P wave. Instead, we see these distinct sawtooth flutter waves that replace the normal P wave, and there's no clear PR interval to measure. So again, instead of those normal P waves, we get these atrial flutter, sawtooth flutter waves, or F waves, that represent that multiple rapid atrial depolarization. So then with the QRS complex, typically this is going to be normal because the conduction through the ventricles is typically going to be unaffected. So now let's talk about what causes atrial flutter. So A-flutter typically occurs in patients with underlying heart disease rather than a healthy individual. So some common causes would be coronary artery disease, hypertension, mitral valve disorders, a pulmonary embolism, the use of certain drugs such as digoxin or quinidine. So now let's discuss how atrial flutter affects the heart and the body. So because the atria are contracting so fast, they're not going to have enough time to completely fill with blood before they have to contract again. So with this, we're going to see a decrease in the cardiac output, as well as reduced blood flow to the body. And also we have an increased risk of stroke due to the potential pooling of blood in the atria. This is more so seen with atrial fibrillation, but it can happen with atrial flutter as well. So let's talk about the symptoms of atrial flutter. So patients with A-flutter can present with palpitations, chest pain, lightheadedness, and shortness of breath. If the ventricular response or the ventricular rate is too fast, then they can also have hypotension as well as syncope. So now let's talk about how we treat atrial flutter and our nursing considerations. So whenever we're managing a patient with A-flutter, we first need to assess whether it's acute or if it's chronic and if the patient is symptomatic. So one of the first things we do is rate control. So if it's too fast, meaning we've got a ventricular rate greater than 100 and they're symptomatic, then we may need to use medications like beta blockers. We can also use calcium channel blockers and antiarrhythmics. So an example of a beta blocker would be like metoprolol. An example of a calcium channel blocker that helps with rate control is going to be diltiazem, and antiarrhythmic would be something like amiodarone. Next, as far as our treatment, we can do cardioversion. So if the patient is acutely symptomatic, synchronized cardioversion may be performed to restore that sinus rhythm. If the patient has been in atrial flutter for an extended period of time, then we always need to assess for clots before we perform cardioversion, just so we prevent any sort of embolism from occurring. 3, anticoagulation. So again, because of the high risk of clots, we're going to put these patients usually on a long-term anticoagulant therapy. And lastly, we have catheter ablation. So for recurrent or persistent A-flutter, then that radiofrequency catheter ablation is oftentimes going to be the preferred treatment to go in and burn off that ectopic focus or that ectopic pathway. Moving on to atrial fibrillation, or AFib. This is the most common dysrhythmia that's seen in clinical practice. It's a very chaotic rhythm that originates from multiple ectopic foci in the atria. So whereas with atrial flutter, we just had that one ectopic focus which created that same little flutter wave, now we've got multiple areas that's starting this electric discharge. Because of this, just kind of think about if you were being electrocuted from all over, you would quiver, right? So this causes the atria to start to quiver rather than to contract effectively. So this causes a loss of that atrial kick. So we don't have a distinct P wave on the ECG, and instead we have a irregular ventricular response. So now let's talk about how we identify this on an EKG. So again, we're always going to count the heart rate. So AFib can have a controlled ventricular response, meaning that the ventricular rate is still between 60 and 100, or it may have a rapid ventricular response, meaning that the ventricles are beating at a rate greater than 100. We talk about that a little bit further on the next slide. So again, you calculate the heart rate, and then we're going to look at the regularity of the rhythm. So if looking at this, you can see how irregular it is. The time between each R-to-R interval is varied. Some it's long, some it's short, and that's what we call an irregular rhythm. So whenever you're listening to these patients, you're going to hear that lub-dub, 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 and you get the picture. But so that is what we call an irregular rhythm, which is very characteristic of atrial fibrillation. So next, remember we look at the P waves. So with this, there's no distinct identifiable P wave. Instead, we see this chaotic fibrillatory wave. And that is how we identify atrial fibrillation, by those chaotic fibrillatory waves between the QRS complexes. The QRS complexes are usually going to be normal in their shape and the duration, which just indicates that conduction through the ventricles is still intact. So let's talk about kind of the pathophysiology for atrial fibrillation for a second. So we know that in a normal heart rhythm, the electrical impulse travels from the SA node, traveling in a very organized manner to produce that effective atrial contraction. However, in atrial fibrillation, we have multiple ectopic sites that are firing at a very rapid rate of usually 350 to 600 beats per minute, which leads to a very disorganized depolarization. The AV node, however, is still serving as our gatekeeper. It's only allowing some impulses to pass to the ventricles, which results in an irregular ventricular rate, usually between typically with like an RVR response, again, that rapid ventricular rate, it can be anywhere from 120 to 200 beats per minute. But otherwise, we can have atrial fibrillation that's still got a controlled rate where we've got the ventricular rate that's less than 100. So atrial fibrillation is very commonly associated with structural heart changes, especially atrial fibrosis and a loss of muscle mass. And we see this with conditions like high blood pressure, heart failure, coronary artery disease, different valvular heart diseases, hyperthyroidism, chronic kidney disease, diabetes, and obesity, as well as having a previous ischemic stroke. Also, AFib can have a genetic component. There are actually up to 30 genetic mutations that are identified as potential contributors to AFib. So now let's talk about AFib's clinical significance and its symptoms. So the loss of atrial contraction in AFib leads to blood stasis. So kind of think about what's happening. As those atria are fibrillating and they're not effectively contracting, that blood is still kind of just sitting in there. Very little of it's actually making its way to the ventricles because, again, those atria are just kind of quivering. So think about what blood does whenever it sits still. It's going to clot, right? So we see blood stasis in AFib, which significantly increases the risk of clot formation. And these clots can travel to the brain and cause an ischemic stroke. They can go to the lungs, causing a pulmonary embolism, and even end up being a heart attack or a MI. So patients with AFib are actually 5 times more likely to have a stroke as compared to those who have a normal sinus rhythm. That's why anticoagulant therapy is such a high priority for AFib patients. All right, so now let's talk about the management and treatment for AFib. So the primary goals in managing AFib are to control the heart rate so that we can prevent complications that come from that rapid ventricular response. We want to prevent stroke by reducing the risk of clot formation, and we want to restore and maintain a sinus rhythm if that's possible. So when we talk about how we control the heart rate, so to slow the ventricular response, especially if this is someone who's got a rapid ventricular rate, which again, I've got a picture on the next slide, so hopefully it'll make more sense. Then we use medications like beta blockers, like metoprolol. We can use calcium channel blockers. Diltiazem is a big one, as well as digoxin. As far as rhythm control, we can use amiodarone or another antidysrhythmic to hopefully attempt to convert or keep a patient in a normal sinus rhythm. When we look at cardioversion, so for unstable patients who have acute onset AFib, such as a new onset of AFib within 48 hours, then synchronized cardioversion may be performed to help restore a normal sinus rhythm. However, if the AFib's been going on for more than 48 hours, then we don't need to attempt cardioversion without anticoagulation, because this patient's going to be at high risk of dislodging a clot from the atria and causing them to have a stroke. So when we talk about anticoagulation therapy, again, because AFib greatly increases that risk of stroke, we need long-term anticoagulation. So we do this with medications like warfarin, which requires monitoring of the patient's INR levels. We can use direct oral anticoagulants like Eliquis, otherwise known as apixaban. That's the name you'll need to know. We also can use rivaroxaban, which is Xarelto, and we can use Pradaxa. All of these medications don't require that routine INR monitoring. If we do a catheter ablation, so for patients who have recurrent or persistent AFib who don't respond well to medications, then we can utilize that radiofrequency ablation to hopefully destroy those ectopic foci in the atria. All right, so now we're going to take a closer look at atrial fibrillation with rapid ventricular rate or response, otherwise known as AFib with RVR. So AFib, like we've discussed, is a chaotic rhythm where we've got multiple ectopic foci within the atria that are firing impulses from all over, causing the atria to quiver instead of contracting effectively. So we see an irregular and often rapid heart rate, as seen on the EKG strip here on the slide. So when the ventricular rate is between 60 and 100 beats per minute, again, that's called atrial fibrillation with a controlled ventricular response. If we're going to have a patient that has AFib, this is where we want them. If we can't get them converted to a normal sinus rhythm, that is. However, whenever the ventricular rate exceeds 100 beats per minute, then we have this atrial fibrillation with rapid ventricular rate or RVR. So this is a much more serious condition because the heart is beating too quickly to allow for adequate ventricular filling. So this is going to significantly reduce our cardiac output. If you look at the rhythm strip here, you can see that classic irregularly regular pattern. Again, there's no distinct P waves, the QRS complexes are occurring in an unpredictable sequence, and the ventricular rate is clearly elevated beyond 100 beats per minute. So this rapid response leads to poor perfusion and hemodynamic instability, which increases the risk of complications like hypotension, heart failure, and even a stroke. So management of AFib with RVR primarily focuses on rate control, which is typically going to be achieved through medications. And one of the most common treatments is a calcium channel blocker called diltiazem or cardizem. This medication is administered as a bolus dose first, and then it's followed by a continuous IV drip, which is then titrated to achieve the desired heart rate. Beta blockers like metoprolol or esmolol can also be used to help slow down the heart rate, especially in those patients who have underlying coronary artery disease. So symptoms of a patient with AFib with RVR, they may have palpitations, shortness of breath, dizziness or syncope, fatigue, chest pain, and hypotension, which again is due to that reduced cardiac output. So it's important to note that while controlling the ventricular rate is the priority here, anticoagulation therapy is just as important because again, blood pools in the atria due to that ineffective contraction. So patients with AFib, especially those who have AFib with RVR, are at a significantly higher risk of a thromboembolic event like a stroke or pulmonary embolism. And that's why anticoagulants like warfarin or direct oral anticoagulants like apixaban or rivaroxaban are prescribed. In severe cases where medications aren't effective, then synchronized cardioversion might be necessary to restore a normal sinus rhythm. Again, cardioversion is generally going to be avoided in any long-standing AFib unless we do a transesophageal echocardiogram or TEE. Usually we see this done like a TEE with a bubble study at the bedside, and this is to rule out the presence of a clot in the heart. All right, so now we're going to shift to ventricular dysrhythmias, which originate in the ventricles rather than the atria. Ventricular dysrhythmias are generally going to be more life-threatening because they can severely impair cardiac output and tissue perfusion. So we have 4 key ventricular dysrhythmias that we're going to go over. We have premature ventricular complexes, or PVCs, ventricular tachycardia, ventricular fibrillation, and ventricular asystole, otherwise known as ventricular standstill, or simply asystole. So each of these can present with different levels of severity, from isolated premature beats with PVCs to a complete loss of cardiac output. Now let's talk about premature ventricular complexes, or PVCs. These are extra heartbeats that originate in the ventricles, and they occur before the next expected normal beat. Essentially, an ectopic focus in the ventricles fires an impulse prematurely, which causes an early QRS complex on the ECG. So one of the key characteristics of a PVC is its appearance. It's wide and it's distorted, and we're talking about the QRS complex here. So a PVC QRS complex, again, is wide and distorted, especially as compared to that normal QRS complex. And this is because the ventricles aren't contracting simultaneously as they should. So this premature contraction reduces cardiac output, and this is because the ventricles didn't have enough time to adequately fill before needing to contract again. So we have different types of PVCs. They can be classified into their type depending on their pattern. So we have a unifocal PVC. So these are going to be PVCs that are originating from the same ectopic focus. So they're going to appear identical in their shape, which is what you see on that top strip. The 2 PVCs that you see there, the wide distorted QRS complexes, you can see they look the same. But if you look at that lower strip, the one on the bottom, there's 2 PVCs, one toward the beginning of the strip and one toward the end of the strip, and they look different. These are what we call multifocal PVCs, and that's because these 2 PVCs are arising from different areas in the ventricles, so they're going to have a different shape. Whenever there's 3 or more consecutive PVCs that run together, then these PVCs can become a lethal dysrhythmia, which is known as ventricular tachycardia, and I'll talk a little bit more about that on the next slide. So PVCs are pretty common. Their frequency increases with age. They can occur in healthy individuals, but they may also be associated with different electrolyte imbalances, especially low potassium or magnesium, myocardial infarctions, heart failure, COPD, nicotine, caffeine, alcohol, stress, or different stimulants, and certain medications like digoxin. Postmenopausal women in particular can experience PVCs due to caffeine consumption. So as far as signs and symptoms go, patients who have a PVC may report feeling a palpitation or a sense of having a skipped or pounding heartbeat. And in some cases, PVCs can lead to dizziness or lightheadedness if the cardiac output is significantly impacted. And again, this is very similar to like our premature atrial complexes, whereas this is just an abnormal finding on an otherwise normal rhythm. So you can see here the underlying rhythm is a normal sinus rhythm, but it just has PVC. So we would call this like normal sinus rhythm with PVCs. All right, so we'll talk a little bit more about these PVCs on the next slide as well. All right, so now let's continue our discussion on PVCs. So again, premature ventricular complexes are abnormal ventricular contractions that originate from an ectopic focus in the ventricles. So these beats occur earlier than the next expected normal beat, and they're typically followed by a compensatory pause before the heart resumes its normal rhythm. On an ECG, PVCs appear as wide and distorted QRS complexes, again, because they don't follow that normal conduction pathway. So now, why do we care about PVCs? So an occasional PVC is pretty common and it may be benign. However, frequent or sustained PVCs can indicate myocardial irritability, which increases the risk of progressing to a more serious arrhythmia like ventricular tachycardia or ventricular fibrillation. In patients who have an acute myocardial infarction or a heart attack, a PVC can actually serve as an early warning sign for impending VTAC or VFib. So now let's talk about the different types of PVCs. So we know that PVCs can occur in different patterns. And we've already talked about unifocal versus multifocal PVCs. Again, a unifocal PVC is a PVC that originates from a single ectopic site, and they appear uniform in their shape, meaning that every PVC that you see on an ECG strip comes from the same site. They all look the same because they come from the same site. Now, a multifocal PVC, this is where we've got PVCs that are coming from different ectopic foci, so they appear different in shape, and that's what you see there on the first ECG tracing on the slide. That first one, that second beat there you see is a PVC, and then a little bit later we see another PVC that looks a little bit different. That's just because they're multifocal. They're coming from two different areas. We can also have what's called bigeminy. So this is a pattern of PVCs where we have a PVC on every other beat. And that's what you see on that third rhythm strip there. You can see there's a normal beat, and then a PVC, and then a little bit later we have a normal beat, and then another PVC, and a normal beat, and another PVC. So again, every other beat is what we call ventricular bigeminy, or like PVC bigeminy. Trigeminy occurs when every third beat is a PVC. That's on the final strip there, the one on the bottom. So you can see every third beat is a PVC, so that's ventricular trigeminy. Couplets are two consecutive PVCs, which is what you see on that second strip there. And then also we have, again, like I talked about on the last slide, when there's a run of 3 or more PVCs together, then that's what we see, or what we identify as ventricular tachycardia. So that ventricular tachycardia, so this would be what you see on that second strip there, what we call a non-sustained ventricular tachycardia. And that's just a run of 3 or more consecutive PVCs before the rhythm tries to take back over. Again, this can progress to a sustained ventricular tachycardia where we just have VTach on our ECG strip. So let's talk about how our patients present. So these patients may be asymptomatic, or they may report palpitations or chest discomfort or feeling like they have a skipped heartbeat sensation. So due to the irregular ventricular contractions, stroke volume is going to be reduced, which can lead to a diminished or even an absent peripheral pulse during PVC beats. So that's why it's so important that we palpate the carotid, the brachial, and the femoral pulses whenever we're monitoring for PVCs. So if you're listening to a patient who's having PVCs and you're feeling like their radial pulse, you may hear the PVC via auscultation, but you may not feel it in their radial pulse, again, because the stroke volume is diminished with these PVCs. So we see those diminished or absent peripheral pulses. So let's talk about our assessment and nursing interventions for PVCs. So whenever we're assessing PVCs, we want to focus on identifying that underlying rhythm. Again, PVCs are not their own rhythm. They're a part of another rhythm, like normal sinus rhythm or even sinus bradycardia. So first, when we see PVCs, we want to determine the frequency. Occasional PVCs may not need treatment, but frequent PVCs can lead to more dangerous arrhythmias, again, like ventricular tachycardia. We also want to check for that pulse deficit. So PVCs, again, may not produce a strong enough contraction to cause that peripheral pulse. That's why getting an apical pulse needs to be done on these patients. Now for treatment and management. So management really depends on the frequency of the PVCs and how the patient is responding or what their symptoms are. So if PVCs are infrequent and they're asymptomatic, we just need to monitor the patient. However, if the PVCs are frequent and the patient is symptomatic, then we need to identify and treat the underlying cause, which may be an electrolyte imbalance like potassium or magnesium. We may need to eliminate certain stimulants like caffeine, alcohol, or nicotine. We may need to correct any hypoxia in the case of a respiratory condition. Also, it may be due to medication, so we need to review their medications, especially medications like digoxin can cause this. When we talk about pharmacological treatment of PVCs, so again, if PVCs are occurring frequently or they're putting the patient at risk for ventricular tachycardia, then we may use beta blockers, calcium channel blockers, or even antiarrhythmics like amiodarone or procainamide. For patients with severe or recurrent PVCs, sometimes an implantable cardioverter defibrillator or ICD might be considered. So as far as management goes, if there's not any underlying heart disease, PVCs usually don't require any treatment beyond just eliminating triggers. Again, caffeine, nicotine, alcohol, and those electrolyte imbalances. So our key takeaways, PVCs are early ventricular beats that can be unifocal or multifocal. Bigeminy, trigeminy, and couplets are very common patterns of PVCs. Frequent PVCs, or a run of 3 or more, can lead to or be called ventricular tachycardia. In a patient with PVCs, we want to assess for those pulse deficits. We want to treat the underlying causes and assess for symptoms. And then our treatment includes correcting those imbalances, avoiding triggers, and using medications if that's necessary. Okay, moving on to ventricular tachycardia, or VTAC. This is a life-threatening dysrhythmia and it requires immediate attention. So again, VTAC is considered whenever we have 3 or more PVCs in a row. So essentially, it can just be a complete run of PVCs. So ventricular tachycardia occurs whenever there is an ectopic focus in the ventricles that is firing repeatedly and it overrides the heart's natural pacemaker. So this causes a rapid ventricular rate, typically between 140 and 180 beats per minute. So VTAC can occur intermittently, which is non-sustained VTAC, which is what we saw on the last slide where we had just kind of a run of 3 or more PVCs. Or VTAC can be sustained, where it lasts longer than 30 seconds. So as far as identifying VTAC on an ECG, so first we look again at the rate. Obviously we can look at the strip and know something's not right because we know what a normal sinus rhythm looks like and this is not it. So our rate here, again, typically our QRS complexes, which these again are just wide and assorted QRS complexes. We have a rate of typically 140 to 180 beats per minute. I know your slide says 101 to 150 or 250, but regardless. Then, so again, we look at whether or not it's regular. These are essentially going to be kind of regular, but as you can see, there's no P wave, there's no PR interval, and each QRS complex is greater than 0.12 seconds. And it's just a series of widened, distorted QRS complexes. So sometimes people say VTAC kind of looks like marching nuns. If you kind of look at these, again, VTAC is going to kind of vary in its appearance, just simply like we talked about with unifocal and multifocal PVCs. Just kind of depends on where that focus is coming from in the heart. But one thing to know is that in patients who go into cardiac arrest, VTAC is oftentimes the initial rhythm before they progress to ventricular fibrillation, which is the most dangerous, most terminal arrhythmia. So we're going to talk a little bit more about ventricular tachycardia on the next slide too. All right, so continuing our discussion on ventricular tachycardia. So getting into our different causes and risk factors. So VTAC is associated with ischemic heart disease, myocardial infarctions, and heart failure, as well as different electrolyte imbalances like hypokalemia and hypomagnesemia, as well as cardiomyopathy, valvular diseases, hypotension. It may be due to some drug toxicity, including from drugs like steroids and different stimulants, especially like cocaine or illicit drug use. These both can significantly increase the risk of VTAC. So let's talk about the different types of VTAC. So VTAC can be monomorphic, which is what you see here on the slides, meaning that all QRS complexes look the same, or VTAC may be polymorphic, where the QRS complexes changes in the size and in their shape. A very special type of polymorphic VTAC is called torsades de pointes, which is rare, but it's oftentimes caused by severe hypomagnesemia, and it requires magnesium sulfate for treatment. So now let's get into the management of VTAC. So with this, first we need to determine whether or not the patient is stable or unstable. And let me tell you, if VTAC comes up on a cardiac monitor, that's a surefire way to get a bunch of nurses run into a patient's room, because we need to assess the patient. We need to see what we need to do. So a patient can be in VTAC on the monitor, but they may also still have a pulse. This is what's called stable VTAC. So if they are in stable VTAC and the rhythm is monomorphic, then typically we're going to administer amiodarone 150 milligrams IV over 10 minutes. If the rhythm's polymorphic, such as with tortisods, we're going to give magnesium. If the medications aren't effective, again, in a stable VTAC patient, then we're going to try synchronized cardioversion. In a patient who has unstable VTAC, which means they do not have a pulse present, meaning we're probably running into this patient's room. Looking at the monitor, we see VTAC, we assess the patient, they have no carotid or femoral pulse. Now we have unstable VTAC, and this is a medical emergency. There is absolutely really no cardiac output going on. So this calls for immediate defibrillation and CPR. So with this, we follow ACLS protocols, which is Advanced Cardiovascular or Cardiac Life Support, which is set forth by the American Heart Association. And through this, we follow their algorithm, and it's to administer epinephrine, 1 milligram IV push every 3 to 5 minutes, defibrillate, that's the biggest thing, and again, we're doing CPR while this is going on. And then we're going to give amiodarone 300 milligrams IV push, followed by a second dose of 150 if that's needed. And then with this unstable VTAC, we're going to continue cycles of CPR, defibrillation, and epinephrine administration until the patient receives, until the patient achieves return to spontaneous circulation, or ROSC, or the code is actually called. So regardless of stable or unstable VTAC, anytime we have unsustained VTAC, meaning that we've got, VTAC that's going on for 30 seconds or more, we have to remember that we have a severe decrease in cardiac output going on, which is evident in our patients through hypotension, pulmonary edema, decreased cerebral blood flow, and cardiopulmonary arrest. So again, these are kind of the things that we see with our patients when we talk about clinical presentation. So the symptoms really just depend on the heart rate and the duration of the rhythm. So some of the slower rates may be tolerated, but patients may still have palpitations, dizziness, chest pain, or shortness of breath due to that reduced cardiac output. Again, these are typically going to be your more stable patients that are able to be awake to complain of this. And then our faster or sustained VTAC can lead to severe hypotension, syncope, and loss of consciousness, again, due to that inadequate perfusion. So some key takeaways here. VTAC is a life-threatening arrhythmia, and it requires rapid assessment. We always want to determine if the patient is stable, meaning they have a pulse, or if they're unstable, which means they're pulseless. Medications like amiodarone or magnesium sulfate can be used in stable patients. And in unstable patients, they require immediate CPR and defibrillation according to the ACLS guideline. So remember, if you ever see this on a rhythm or see this rhythm on a monitor, we need to act fast because this is a code blue situation and every second counts. All right, so now let's talk about ventricular fibrillation, or VFib. And this is a life-threatening cardiac rhythm, and it's considered a medical emergency. So what's happening in AFib? So ventricular fibrillation is the result of total electric chaos in the ventricles. So instead of that coordinated contraction, we have multiple ectopic foci that are firing off in a completely disorganized manner. So kind of like we see in AFib, in VFib now it's the ventricles that are quivering instead of contracting, which means there is zero cardiac output. So the heart is essentially not pumping blood at all. So how does this patient, or how does this present? Well, since there's no cardiac output, the patient's not going to have a pulse. They're going to be unresponsive, and they're going to be apneic, meaning they're not breathing. Without immediate intervention, this rhythm is rapidly fatal, usually within 3 to 5 minutes. So what causes VFib? VFib is oftentimes the first manifestation of coronary artery disease, or an acute myocardial infarction, or MI. It may be due to electrolyte imbalances like hypokalemia or hypomagnesemia, severe hemorrhage or shock, drug toxicity, including certain antiarrhythmic medications, surgical complications, or trauma. So now let's talk about what VFib looks like on an ECG. So looking at this ECG, you'll notice that it's just a completely chaotic rhythm. There's no discernible P waves, PR interval, or QRS complexes. Essentially, it just kind of looks like someone scribbled across the ECG strip. It's random and it's irregular waveforms. The heart rate essentially is 300 to 600 beats per minute, but it's not actually producing any meaningful contractions. So what do we do as far as our intervention? So this patient is in cardiac arrest, so we need to act immediately. They're dead, for a lack of better words. So we need to check for a pulse. If they don't have a pulse, then we're going to start high quality CPR. This patient will not have a pulse. The only time that we need to check is if maybe we're seeing artifact on the ECG monitor, but if it is true ventricular fibrillation, they're not going to have a pulse. So again, we're going to check and start high quality CPR immediately. We'll call a code blue and ensure that we have a defibrillator available. So defibrillation is our priority treatment. The sooner that we shock the heart, the higher the chance of restoring a normal rhythm. So as far as CPR and defibrillation are concerned, that's our priority. But again, we're still going to administer medications following that ACLS protocol. And it's the same as what we do for VTAC. So epinephrine, 1 milligram every 3 to 5 minutes. After that first dose of epinephrine, we're giving amiodarone, 300 milligrams. If it's needed, we'll give a second dose of amiodarone, being 150. And then we're just going to continue alternating epinephrine with CPR and defibrillation, hopefully until we get a return of spontaneous circulation, or ROSC, or until they call the code. So key takeaways here: VFib means there's no cardiac output, which means we don't have a pulse. Therefore, immediate CPR and defibrillation are critical. Early defibrillation improves survival. We're going to continue the cycle of CPR, defibrillation, and epinephrine and amiodarone until ROSC, or again, return of spontaneous circulation, is achieved. So as soon as you see this rhythm, we start CPR, we call a code, we defibrillate the patient, and we give the necessary medications, because without immediate intervention, this patient will not survive. All right, now let's talk about ventricular asystole, which is also known as ventricular standstill, or just simply asystole. So this is the complete absence of any electrical activity in the ventricles, making it one of the most lethal dysrhythmias. Physiologically, there's no electrical impulses that are traveling through the ventricles, meaning there's no ventricular depolarization, no QRS complexes, no contraction, and therefore no cardiac output or perfusion to the rest of the body. So this rhythm is often the final stage of a cardiac event, meaning the patient is in a full cardiac arrest. As you can see on the ECG sample on the slide here, the baseline is almost flat with no discernible electrical activity at all. So causes of asystole. So asystole is commonly going to be caused by severe myocardial hypoxia, which is oftentimes a consequence of advanced heart failure or prolonged cardiac arrest. It may be due to electrolyte imbalances like severe hyperkalemia, acidosis, and different metabolic disturbances, and severe conduction blocks, where the atrium may still be able to produce PUAs, but those signals don't get through to the ventricles. In our assessment of a patient who is in asystole, the patient's not going to have a pulse, they won't have any respirations, they won't have a blood pressure, and they're going to be unconscious due to the lack of cerebral perfusion. As far as our treatment and management, so asystole is a non-shockable rhythm, meaning that defibrillation is not indicated. I don't care what Hollywood and the movies say, you do not shock asystole. Reason being is there's really nothing to shock. If there's no electrical activity happening, defibrillation's not going to help. Because defibrillation just kind of helps restart or kind of reset the electrical activity. Here, there's not any. So instead, our priority intervention is going to be immediate, high-quality CPR and following those ACLS guidelines. So we're going to start CPR immediately. This is important to try to conserve and preserve brain and organ function. Then the only medications we're going to give is, or really according to ACLS, is epinephrine, 1 milligram IV push. We can give some other medications, especially if we kind of possibly know an underlying cause or anything like that. If we get return of spontaneous circulation, or ROSC, that's yay, we got our patient back. However, otherwise, we're just going to continue CPR and epinephrine administration until the code is called and the efforts are not successful. So, unfortunately, the prognosis for asystole is very poor, especially if the patient has been in this rhythm for an extended period of time. However, quick intervention and adherence to those ACLS protocols can give the patient the best chance to survive. And for our final rhythm we're going to go over here, we have pulseless electrical activity, or PEA. And this can be a very confusing concept, so we're going to break it down. So first, let's focus on the name itself, pulseless electrical activity. So what this means is there is an electrical activity that's visible on the cardiac monitor, but there's no mechanical contraction of the heart. So in other words, the heart's electrical system appears to be functioning, but the heart is not actually pumping blood. So this means the patient won't have a pulse, they won't have cardiac output, and without any immediate intervention, no chance to survive. So, and I will say this slide is kind of deceiving. Typically with PEA, they have no pulse, but they don't have this pretty kind of normal sinus rhythm looking rhythm on the monitor. It's usually they've kind of got some, deflections here and there, and something that might kind of look like a QRS here or there. But it's really just they don't have a pulse, and it's not really a good rhythm that you see on the screen. But regardless, there is some sort of electrical activity that's happening, there's just no pulse. So this rhythm is oftentimes seen after defibrillation, and it's associated with a very poor prognosis, especially if the underlying cause isn't treated correctly. So some of the common causes of PEA, which really are common causes of asystole, VFib, and VTAC, we kind of look at what we call the H's and T's. So causes that start with H: hypovolemia, hypoxia, hydrogen ion or acidosis, hyperkalemia or hypokalemia, hypoglycemia, and hypothermia. And then we also have our conditions that start with T's, which would be like different toxins such as a drug overdose, a cardiac tamponade, a tension pneumothorax, a thrombosis, whether it be pulmonary embolism or a myocardial infarction, or it may be due to trauma. So PEA, a lot like asystole, is not a shockable rhythm. Therefore, defibrillation is not indicated. So instead, our priority is immediate CPR and identifying the underlying cause. So again, to treat PEA, since the heart's not pumping, we need to act very fast, following the guidelines for ACLS for PEA, which again are very similar to asystole, which are to start high-quality CPR, administer epinephrine, and identify and treat the underlying causes. So key takeaway here for PEA, organized electrical activity does not always mean a functioning heart. So the most important step is to check for a pulse. If there is no pulse, we're going to start CPR and start looking for a reversible cause. All right, so whenever a patient goes into cardiac arrest, immediate intervention is critical to increase their chances of survival. So CPR, or cardiopulmonary resuscitation, also known as basic cardiac life support, or BCLS, needs to be initiated without a delay. When asystole and pulseless electrical activity or other life-threatening arrhythmias occur, this is what we need to do. So you should know all of your steps for high-quality CPR, but we're going to go over them. So first, you want to check for unresponsiveness. If the patient's not responsive, we're either going to call 911 or activate the emergency response team in the hospital. Then we're going to retrieve a automated external defibrillator or an AED, or just our defibrillator we have on our crash cart. And this is a priority whenever we suspect a cardiac arrest. Then we're going to assess for a carotid pulse. We can also assess for a femoral pulse. So we're going to check for 5 to 10 seconds. If we don't detect a pulse, then we're going to begin CPR immediately. Then we'll start our chest compression. So we want to perform 100 to 120 compressions per minute on adults at a depth of at least 2 inches, but no more than 2.4 inches. We want to push hard and fast to make sure we have adequate circulation. And also we want to allow for that full chest recoil between our compressions. We also need to maintain an airway and breathing. So we may need to open the airway using that head tilt chin lift method. We may need to provide rescue breaths at a rate of 10 to 12 breaths per minute. And if the patient does have an advanced airway in place, such as an ET tube, Then we'll give 1 breath every 6 to 8 seconds, which is about 8 to 10 breaths per minute. Our compression to ventilation ratio is going to be 30 compressions to 2 breaths if an advanced airway is not in place. And then, as always, we want to minimize any interruptions. So we want to limit any pauses to less than 10 seconds to help maintain perfusion. And we want to change compressors every 2 minutes so that we prevent fatigue and ensure that we have effective compressions. All right, and lastly here we want to talk about defibrillation. So this is a critical life-saving intervention that's used to treat lethal dysrhythmias like VFib and VTAC. Again, pulseless VTAC. It delivers an asynchronous electrical shock to the heart, depolarizing a critical mass of the myocardium and allowing the sinus node to regain control. So an automated external defibrillator, or an AED, allows for earlier defibrillation, which improves survival rates. It increases the chances of successful rhythm conversion, especially when used very promptly in a cardiac arrest situation. Now, when we look at defibrillators, which is like what we're going to see on our crash carts, there are really 2 types of defibrillators that are used in practice. We have a monophasic defibrillator or a biphasic defibrillator. So a monophasic defibrillator delivers a single current in one direction, and the standard energy level is 360 joules per shock. With a biphasic defibrillator, this has a 2-phase current, which makes it more efficient, and it requires lower energy levels for the same effect. So here, the recommended initial dose is going to be 120 to 200 joules. So now let's talk about for a second the defibrillation protocol. So defibrillation, again, is a treatment of choice for pulseless VTAC and for VFib. We need to make sure we have the pads placed in the right areas on the patient. So ensure that they're placed on the patient's chest as shown on the illustrations. We need to charge the defibrillator. To always make sure it's turned on. It's like the first step with defibrillating. Then we'll, again, charge it to the appropriate joule setting. Clear the patient, which means make sure no one is touching the patient before we administer the shock so that we prevent any injury. Then we administer the shock and immediately resume CPR. So, takeaway here, early and effective defibrillation can significantly improve survival rates in cardiac arrest. We're always going to prioritize CPR and rapid defibrillation for VFib and pulseless VTAC. And that's all I have for you guys on this lecture. See you in class.